practice for the diagnosis and confirmation of death in children and infants older than 2 months post-term follows the recommendations of the Academy of Medical Royal College's guidance published in 2008. This code endorsed the guidance published in 1991 by the British Paediatric Association, the professional representative body of paediatricians in the UK, which became the Royal College of Paediatrics and Child Health in 1996. Death is defined in the paediatric patient in the same way as an adult, an irreversible loss of the capacity of consciousness and an irreversible loss of the capacity to breathe. The preconditions described throughout this guide are the same. The tests should be completed in an unhurried manner and time should be spent making sure that all the preconditions are met.
So these are Thomas's notes. As I say, he's a 7-year-old boy, nearly 8, who came in.
Tests should be carried out by 2 senior medical practitioners who've been registered for a minimum of 5 years, have been trained to carry out the tests, and are not members of the transplant team. One of them should be a consultant.
The bleed is massive, you've got all that edema around it. And
one, a paediatrician, or have experience in paediatrics. One of the individuals should not be primarily involved in the child's care. As in adult practice, the testing of brainstem function in children should be undertaken by the 2 doctors together and must always be performed independently, completely and successfully on 2 occasions in total. Most units offer the parents the opportunity to observe the clinical tests, and it's important that they're supported and kept informed by an appropriate member of the team during the clinical examination if they choose to stay at the bedside. There's no evidence that any defined time period between testing is required. In summary, the preconditions detailed in the 2008 Academy of Medical Royal College's Code of Practice and also expressed in the less detailed 1991 British Paediatric Association document should be fulfilled before diagnosing death by neurological criteria in children older than 2 months post-term. The preconditions are as follows. The patient is comatose, apneic and mechanically ventilated. There is a confirmed diagnosis of structural brain damage or the immediate cause of the coma is known. All potential causes of reversible coma have been excluded. Drugs are not the cause. Neuromuscular blockade has been demonstrably reversed. Hypothermia does not exist. Core temperature is greater than 34 degrees centigrade. And there is no evidence of potentially reversible circulatory, endocrine or metabolic disturbances that could be the primary cause of unresponsiveness. If there are concerns regarding residual effects of drugs, this period can and should be extended. The clinical test for the diagnosis of death by neurological criteria should only begin after both doctors undertaking the tests are satisfied that the preconditions have been met. The tests provide information about the integrity of the brainstem at various levels. The 2 doctors should work together not only to undertake the clinical tests, but also to ensure the preconditions are met.
So can you just help me?
The same 2 doctors carry out both sets of tests. 2 complete sets of tests should always be undertaken, 1 set by each doctor. The tests are as follows. The first is a pupillary reflex test.
Okay. Could somebody turn the lights down for me, please?
The pupils should be fixed with no direct or consensual reflex to light.
And Thomas's eyes. No response there, is there?
No.
They do not need to be the same size or shape for the diagnosis to be made.
Okay, thank you.
Corneal reflexes should be absent bilaterally with no blink following stimulation of the cornea with gauze swab.
So if you could help me open the eyes.
No.
Touching the coloured bit of his
I
eye
can't
there.
feel anything.
No, okay.
there's
The
nothing.
cornea
All right.
and not the
That's
sclera
clear.
should be tested.
I can't feel any sort of twitch at all. You're definitely touching the coloured cornea, so no, nothing.
No motor response within the cranial nerve distribution should be present to a painful stimulus applied centrally.
You see everything?
Yep.
So, ready for supraorbital pressure?
Yeah.
Okay, sorry Thomas.
Spinal reflexes may persist and can be interpreted as such if peripheral movement occurs to peripheral stimulation.
So I'll squeeze his toes now.
Peripheral movement to supraorbital stimulation is not a spinal reflex.
And nothing on the monitor.
Suction down the endotracheal tube with a suitable length of catheter to stimulate the carina will demonstrate the absence of a cough reflex.
Could you just disconnect him for me?
Ensure that the suction catheter is long enough if the endotracheal tube has not been cut.
I'm hitting the carina there now.
Yeah, definitely. No, there's no cough.
Oh, okay. Pass me a tongue depressor and a yanker. Thank you, Dale.
A yanker sucker to suction both sides of the pharynx will demonstrate the absence of a gag reflex.
Can you see the back of the pharynx there?
Just
Yeah.
make sure you get a bilateral stimulus.
Okay.
I can't see any gag or cough.
The vestibulo-ocular or caloric reflex is tested by initially examining the ear canals with an otoscope to ensure clear passage of cold water to the tympanic
Look on the
membrane.
other side.
Yes, please.
The head should be flexed to 30 degrees to the horizontal. 20 to 50 mils of ice-cold water or saline should be injected through a quill into the external auditory meatus over 1 minute with the eyes held open. A receptacle can be used to collect the water as it leaves the ears. The eye should be observed over this minute. Eye movements are typically nystagmus, but any movement in either eye means that the reflex is still present.
No nystagmus, no movement.
The apnea test should always be the last test performed to avoid unnecessary hypercarbia if any previous tests have revealed reflexes to be present. In practice, the actual apnea test should be completed in the same way as in adults.
Okay, we've got our first carbon dioxide and pH.
The patient should be cardiovascularly stable and the minute volume should be reduced to allow the partial pressure of carbon dioxide to rise above 6 and the pH to fall below 7.4. The patient should be pre-oxygenated with 100% oxygen for 5 minutes prior to disconnection. The end-tidal carbon dioxide and oxygen saturations should be monitored, and the child is then disconnected from the ventilator and oxygenation is maintained by instilling oxygen via a loose-fitting suction catheter at a rate of 2 to 6 litres per minute. Alternatively, a T-piece, Mapleson C-circuit or Neopuff can be used depending on the child's size.
And that's the start of the clock.
The child's abdomen and chest are exposed and observed for a full 5 minutes to ensure there is no respiratory movement. It's not uncommon to observe abdominal pulsation from the aorta during the test, and this can be confirmed by timing the pulsations with the ECG monitor.
Right, that's 5 minutes, Kay. So we can
After
do another
5
gas.
minutes, another arterial blood gas is taken to confirm a minimum carbon dioxide rise of a minimum of 0.5 kilopascals. The patient is then reconnected and stabilised, and the arterial gas is returned to the patient baseline to prepare for a second test. Time of death is recorded at the time of completion of the first set of tests.